Thank you so much, Susie. First, I will start with the slide that you wanted me to talk about, optimization. So the way we typically do it, we plan and optimize a VMAT portion as one plan with all the 3 isocenters. So first we perform field in field for APPA portion of the plans for the legs. And then the dose is set as the base dose for VMAT optimization, and VMAT portion is optimized as one plan with the auto-feathering beam junctions. So here you could see the constraints we use for planning. We typically normalize the plants to the 90% at prescription dose, and we aim to spare lungs, kidneys to the mean of approximately 55–60% of prescription. And as Susie mentioned, for patients without active disease with a 2-gray prescription, for example, we spare other organs like brain, thyroid, testes, in addition to lungs and kidneys. And after plan is optimized, we set the dose rate for ARCs that treat lungs to lower dose rate, 100 to 200 MU per minute. This is a controversial topic. So there's a debate currently within institutions that are treating VMAT TBI. Some institutions do not lower the dose rate at all. We are trying to be a little bit more conservative and follow the historical treatment of lowering the dose rate. So we try to keep the average dose rate at lungs less than 20 centigrade per minute. And the way we do all the calculations, optimizations, we typically use 2.5 millimeter dose grid resolution, and we use AAA V15.6 version in Eclipse. But this is kind of a transition slide between our presentations. So as you can see, the complexity is quite high for VMAT TBI planning. So initially, when we introduced this program at Stanford, I was doing all the planning and I was doing it manually. It would take me a few days at least to finish up. So even to start the optimization, it takes minutes, the order of half an hour. So because of the large data sets. So obviously we needed to improve, and we decided to tackle this problem with automating the treatment planning process using Eclipse API framework. So what's great about Varian and Eclipse, they open their API to anyone who wants to do scripting and automate planning, automate plan check, and we are actively using it at Stanford. So one of the bright physics residents at Stanford at that time is Eric Simila. He worked with me on this project. So to make VMAT TBI even more prevalent across the country, we also posted the script to GitHub, so it's available to anyone who wants to use it, who has Eclipse treatment planning system and who has Varian machines. It doesn't have to be a true beam, but it's a VMAT enabled Varian machine, and you can use the scripts. So there's also a video presentation that Eric gave about it. So if you Google VMAT TBI Stanford. So I will continue with description of the scripts. So there are 2 scripts that we developed: the binary plugin that's used in Eclipse, and the standalone executable that's used to optimize. So the first binary plugin generates optimization structures, flash targets, generates plan, places beams, creates optimization constraints, and also prepares plan for treatment after physician approves it. It's very user-friendly, modular, and fast. So we created it for dosimetrists, for planners. They can adapt it, and they can modify with any constraints they need to use, particular for that specific patient. But overall, it works on defaults as templates. So you can select the regimen you're treating with, prescription, it loads all the defaults, and user can modify as needed. And so here you could see the example of a standalone executable script that's run outside of Eclipse. In a newer version of the scripts, we incorporated this portion into the Citrix environment, so it can be launched directly from Eclipse. You don't need a thick client for this. So it runs successive optimization, updates optimization constraints, following each optimization. So it basically imitates all the manual steps in the process of optimizing. It does not require user intervention. So the way we typically use it, we run it before we go home, start it, and then at the end of the day, and then come back in the morning for the plan ready for us to review. So it takes usually 3 to 5 hours for 3 optimizations. And the reason it takes that long to optimize because of the size of the CT scan, because of scanning the whole body. So now switching gears and coming back to our workflow. So after physician reviews the plan, the plugin script is run again to help prepare plan for treatment. It separates the VMAT plan into separate plans per ISO, generates shifts node automatically, removes virtual bolus, recalculates the dose. And we created another script, automated plan checker, that automates physics plan checks for inspecting more than 180 plan elements and outputs the DVH constraint metrics. And it's something that Ignacio is actively working on to adapt for VMAT TBI. And for therapist guidance was set up, so you could see the spreadsheet that was created in ARIA documents to propagate couch longitudinal values based on the first chest cone beam CT ISO. So longitudinal positions of the couch have to be preserved. So how do we perform the quality assurance for these plans? We always do this before first fraction for individual VMAT plans using portal dosimetry EPIT here with 3% 2 millimeter gamma criteria, passing more than 90% points. All plans pass QA within the average of 98% approximately of points passing gamma 3% 2 millimeters. So you could see that the passing results are quite excellent. For the secondary dose verification, we also do the Mobius 3D that is now offered by Varian. So we observe the minimal differences between Mobius collapse cone convolution algorithm and Eclipse AAA calculated in PTV D mean and also LAN D mean dose. So how do we actually treat? So for image guidance, we start with imaging chest ISO with KV-KV pair. Then we perform cone beam CT. We deliver that chest ISO plan. Then we shift to head ISO, acquire MV port, add it to ARC, and then treat. Then we shift to pelvis, acquire MV port, for verification, treat, and so on. Then we spin the patient around like you saw in the video that Susie showed, and we treat then the upper leg ISO with porting, and then treat the lower leg ISO with porting before the treatment. We typically allow 5 millimeter lateral shifts and no vertical or longitudinal shifts. So this is more for Stanford physicians when you're reviewing the images. Since there is a flash added, 5 millimeter flash, so there's a lot of less of the requirement to have the patient exactly set up. As you can imagine, for the whole body alignment, there might be difficulties in setting up certain parts of the body, especially the extremities. That's why we add this margin, 5 millimeter margin. And so you could see the ports here for MV, for the legs especially. There's less of a requirement for accurate placement of extremities because we are using the open fields for legs, 40 by 40 fields, and we do slide field in fields to get rid of the hot spots of the match line areas. So in terms of treatment time, how long does it usually take? So based on our first 35 patient experience, the treatment time ranged between 20-something minutes to 73 minutes, and the average was around 50 minutes. So most pediatric patients were watching movies during treatment using Avatar system. That's something that Susie and the team pioneered here at Stanford. We actually sent one Avatar system to Ohmedit Kyiv. So there were 6 patients out of these 35 patients initially treated that were treated with anesthesia. Anesthesia obviously takes more time to do. So for matchline dose verification and testis dose verification, we use nanodots or OSLDs. We place them on the skin, on the match line, to verify the accurate match line. And accurate treatment. So actually the dose, average match line dose matched well the planning dose. We also performed the robustness evaluation for VMAT TBI plans. So the way we did it, we introduced intentionally 3 types of deviations. So first one was a local lateral 5mm shift of head isocenter relative to chest isocenter, and we looked at its effect on PTVD max and LAN-D mean. We also looked at a local longitudinal 5mm shift of upper legs APPA iso towards pelvis and simulated what would happen to the dose distribution. And the third one, we looked at the global 5mm shift in all directions for VMAT plans and its effect on PTV Dmax. So you could see the dose shifting around. So when we looked at all these 3 scenarios, we found that when we move head isocenter 5mm relative to chest iso, the deviations from planned dose were quite small for PTVD max and LAN-D mean, on average around 1%, and the global shifts of 5mm in all direction produced mean and maximum differences of around 2% and 5%. So, but the greatest discrepancies in PTVD max were observed when upper leg isocenter was moved towards the pelvis isocenter, with the deviation around 11% on average, but the range of 3% to 22%. But there are usually no OARs affected by this deviation, as the match line was in the leg area. And as indicated by our nanodot measurements, the match line was executed accurately for all our 35 patients. Then we did the comparison of for 10 first patients that we treated with manual VMAT TBI plans. We created the auto-generated plans using the scripts, and we compared the appropriate dosimetric indices. For the same target coverage, the global Dmax and PTV 110% was the same, but LANS and LANS minus 1 cm D mean was lower, actually was auto plans. And so we also asked physicians to review these plans in blinded fashion and found that overall the auto plans were marked as either equivalent or superior to manual plans 77% of the time. And only one plan for patient 3 was actually marked as inferior because of the gonadal sparing. But we found that with one additional optimization to lower the dose to testes, the dose was improved. And this is the results from one of our publications from experience of the first 35 patients treated with VMAT TBI with this technique. So you could see there's a wide range of height and width. So we treated a patient up to 60 centimeter wide and the height of up to 190 centimeter. All of them had the average LAN dose approximately 55%. So we were actually meeting the constraints. And the Dmax PTV D1cc was on average around 120%. We also spared kidneys to they mean around 70%, and for benign diseases, gonads were spared to 1/3 of prescription dose, and brain and thyroid spared to 2/3 of prescription dose. And so how does VMAT TBI plant quality compare to conventional TBI? One of our excellent dosimetry students at the time from MD Anderson, Nick No, now he's one of our dosimetrists, worked on dosimetric comparison between 2D and VMAT TBI plants. So his paper recently got published. For 10 patients treated with VMAT TBI, conventional 2D TBI plants were created. So you can see the dose distribution differences, and you could see quite an inferior sparing for the lung with 2D plants, even though we are using 50% blocks. But when you actually calculate the dose, so including all the scatter, the mean lung dose with 2D plants are actually around 25% higher compared to VMAT TBI plants. And if you look at the structure representing the actually lung spared with 2D, which is lungs -1 cm, it's around 35% higher with 2D plants compared to VMAT TBI plants. So here you could see the representation of this with the DVH, so one for one of the representative patients. So PTV is actually better covered with VMAT, so you get 90% of PTV covered by prescription dose. The hotspot is actually equivalent, the same, versus with 2D around 30% of the PTV gets the prescription dose. Also, you could see the drastic changes in lung sparing. So the lung mean dose for this patient is around 80% versus mean lung dose around 50% for VMAT. Testes as well, so you could spare testes much better with VMAT. Even if you simulate it with 2D using testis blocks, which we never actually do in the clinical practice. So these are the examples of gonadal sparing TBI plants for a boy and a girl, and their comparisons with 2D plants. Gonadal sparing is superior and more practical with VMAT TBI plants. And so this one, maybe I will ask Susie to comment. Susie, if you can unmute.
Definitely. Thanks. Yeah, so this was our patient outcomes that we wrote up with our excellent resident, Dr. Hui, and medical student, now Dr. Marquez. And this looked at our experience with our first 38 pediatric and young adult patients treated with VMAT TBI, and how they did sort of in the short to intermediate stage. So our follow-up for this was a mean of 10 months, which is enough for us to see the acute toxicity and the subacute toxicity, not really the late toxicity yet for the most part, but just to see how are they doing at this time point, and give us a hint too, as we talked about that, the leukemic relapses when they happen tend to happen pretty early. Just give us a clue if there were any issues with that or any issues with graft failures, et cetera. And so what we found, this was a sort of a mixture of both our myeloablative patients and non-myeloablative, about half and half. We found really that at this early time point that they were doing quite well with overall survival of about 90% and 95% relapse-free survival with really well-tolerated treatment. Pneumonitis, there's only one patient, and that was not actually radiation attributed, really. It was present before, and it was a grade 2. And then other toxicity was pretty minimal. The nausea is something that's significant, and we probably see at least as much with VMAT as with the standard 2D technique. Something that we also think about is just because the treatment is longer, sometimes the patient is lying on the table, starting to get nauseated. That's a possibility, as opposed to, the 2D treatment is so short, it's about 8 minutes or 10 minutes. And so they're at least out of the booth usually before they get nauseated. So it's certainly something where we think about making sure the pre-meds are good. Otherwise, these are really quite in keeping with what we expect for TBI side effects in the short term.
And something that we did, we retrospectively looked at patients treated with 2D TBI and tried to match the cohorts. We actually found that toxicities, the grade 3+ toxicities were almost double with 2D TBI compared to VMAT TBI. We were initially concerned about mucositis, high mucositis with VMAT TBI, but actually when we look at mucositis with 2D TBI, it's double that of VMAT TBI.
Yeah, agreed. And it can be tricky too, just in terms of these transplant patients and figuring out toxicity with the chemotherapy that they get, which also all causes mucositis, a little bit tricky to tell too what's what.
And this is one of our last slides. And this is a table that is from one of our papers, VMAT TBI techniques in the literature. I'm not going to go into too much detail on this, but there are many different institutions that are now trying to apply VMAT TBI in their clinic, and they slightly do things differently. So it'd be great to have a consensus between institutions, and that's something that we are working on. So I have a poll question here. Let's see if I can launch it. Okay, so the question is, what benefits does VMAT TBI offer? So you can read all the answers and try to choose the best answer you can. So that's great. So all of the above. Okay, and another question, what are the drawbacks of VMAT TBI? A, complex treatment planning delivery. B, inferior organ sparing compared to 2D TBI. C, increased dosimetric uncertainty in field junction. And D, all of the above. So the drawbacks of VMAT TBI is actually the complexity, complex treatment planning delivery. But I think we have more gains with VMAT TBI. Okay, and this is the really last slide, conclusions and future directions. So as a conclusion, VMAT TBI is a modern alternative to conventional 2D TBI treatment. It offers possibility of organ sparing, simultaneously integrated boosts, accurate dose calculation, image guided delivery, more comfortable patient positioning, definitely lying down. Our pediatric patients are even watching movies during treatment. And also we have an ability to treat VMAT TBI patients in small size vaults, so we can potentially treat those patients on many different machines within our clinic. So and regarding the scripts, they really cut down and reduce the time for planning from days to few hours. And if you have a variant VMAT enabled Linux, you can download those scripts. You can search for GitHub, VMAT TBI, Stanford, and Eric's folder. You could download the scripts and start using it. And if you need instructions how to do it, we can help you out. So we treated more than 100 patients now with VMAT TBI since its initiation 2019. We are preparing for ASK4 and COG workshop to talk and teach other institutions how to do VMAT TBI based on our technique. And recently we introduced the VMAT TBI portion of this technique on the clinical trial, ASCT 2031 clinical trial. So our Stanford VMAT TBI technique is featuring there as the VMAT TBI portion of the trial. Okay, and I would like to acknowledge the whole Stanford team working on this, and thank you so much for your attention, and then we'll be open up for questions. I'll stop sharing so you can ask questions, turn on the camera, or you can type it in the chat.
Hello, do you hear me, Natalka?
Yeah, we can hear you, Nadia.
Yeah, my name is Nadia. I'm a medical physicist from Kyiv. I have one question about the VMAT technique in TBI. Do you control the jaw positions when you do the VMAT planning between different isocenters? Because I think about this junction of this area where the fields are overlapping, and I don't know how it works for you.
Yeah, that's a great question. So we do control the jaw positions. Actually, the script automatically creates the fields for us and creates the overlap junctions. So we typically try to get ideally at least 5 cm overlap. We cannot do it always, so minimum 2 cm to 5 cm overlap. And why it's needed, we use auto feathering while we're optimizing. So auto feathering creates this the slight dose fall off from one field to the other. So if there is a small discrepancy between isocenter positions longitudinally, you don't create very high spikes of hotspots or low dose valleys. So this overlap is actually needed, really required to create a homogeneous dose distribution when you actually deliver it on the machine. And we also use jaw tracking. So we use, we do it on TrueBeam, and we use jaw tracking, but jaw tracking is not really required and necessary. The main thing is that overlap, initial overlap when we start optimizing.
So you have jaw tracking, if I understand right, the jaw tracking, the jaws are moving during
That's
the
right.
delivery and treatment, yeah?
Right.
But how the junction is controlled? How do you do that? You do some how do you control the jaws during their move? I don't understand.
Yeah, so it's controlled initially. So when you start the optimizer, your jaws are preset, and it's typically using that jaw position. It might slightly close for certain control points, but typically keeps those jaw positions where you set initially.
Okay. Okay. Thank you. Thank you.
Yeah, it's a good question. And for APPA plants, we actually do matching on skin, so there is no overlap there. Any more questions?
Hello, Natalia.
Hello, Serhi.
Yes, related to this question that you just answered, so what would be your recommendations on controlling the spikes? Like if it happens so that there is a mismatch of isocenters, let's say 0.5 centimeter or 3 millimeters or less, what would be the correctness of the plant? So the spike would be, for example, 115% or 110%. Is there some standardized recommendation of that?
Yeah, so it's a good question. That's again relates to robustness of planning and auto feathering junctions. So it's important to have that overlap. The more overlap you have, it's actually slower gradients from one field to the other, from one ISO to the other. So then it would create less of the spikes or less of the cold spots. We first control it with amount of overlap, and second way, the way we control it, we do so-called dosimetric shift. So we absolutely instruct the therapist to maintain the same shifts what's specified by the plan. So even though the positioning might be slightly different, but we maintain exact longitudinal shift from one isocenter to the other. And for that, we are using the spreadsheet in ARIA documents where therapists first start was including the parameters for the cone beam CT, couch positions after cone beam CT matching for a chest isocenter, and they are populated for all other isocenters. And then the therapist shift exactly the same longitudinal amount that's specified by the plan, calculated by the plan.
Thank you very much.
Any other questions? Susie, I have a question for you. If let's say if we were to start the TBI program in Ukraine, what would be your suggestions and recommendations how to get it started?
Enter the VMAT TBI?
Yeah.
Yeah, you know, I think that a lot depends on the BMT teams, the transplant attendings that you're working with. I think ours have been very kind of accepting and welcoming of this new technology that we think is better. And I think they sort of like trust us on the radiation aspects of things. And so we've gotten a lot of, you know, I guess buy-in from them and support, which I thought was true everywhere, but then it's like sometimes we give little speeches to other centers and it seems like their transplant attendings or the medical oncologists have a lot sort of stronger opinions about the radiation, whether, you know, how well informed it is, I'm not totally sure, but they feel a lot more ownership of it, which seems to me that would be more difficult to deal with if your transplant team wasn't sort of, you know, supportive of you making the best radiation decisions. So I guess the first part would be to, you know, talk to the transplant teams and, you know, let them know, like with a little presentation of why we think this is better, et cetera, and get their buy-in. And then I think, you know, yeah, I think it's been great for us. If anything, our transplant team, we have the opposite problem where they want everybody VMAT TBI now because they love it. And we're like, oh, we can't do everybody yet. We don't have the bandwidth. But I think it's just like a partnership, and hopefully, you know, I think it's great if they sort of, the transplant team kind of respects the radiation team's, you know, basically thoughts and doings on that side.
Yeah, that's great. I actually have good news for you, Susie. We are getting more spinning manis.
Oh, yay, we need more spinning
Yeah.
manis.
So we possibly can treat more patients with this. Yeah,
Great.
Potentially all. And maybe one of the potential next steps would be to open up the trial for adults. So that would be something.
Yeah, exactly.
Okay. Any more questions? Okay, thank you so much. That concludes our session. And so this Friday, we will have a session on CSI. So stay tuned. Thank you for joining us today. Bye-bye.
Thank you.